Good evening, sir. So you're also a doctor. So do you miss your doctor life or not? And secondly, if given an opportunity, would you choose the same? Would you make the same choice of choosing administration?
The answers to both the questions are yes and yes. I do miss medical work and medical life because there's nothing more exciting than actually doing something directly to a patient, seeing the person relieved of pain, or sometimes, if you're lucky, even saving a life or two. I'm one of those lucky ones, though my medical practice was very short as a house surgeon. There were a couple of occasions when I actually could save life. One was hypoglycemic coma. It was not even my patient. So around 2 o'clock in the afternoon, as I was walking along the corridors, a nurse ran up to me and said, "Doctor, the patient is in critical condition. Will you please look at her?" As you know, the etiquette in hospitals is you don't attend another patient unless that patient belongs to your ward or something. But because the patient was in critical condition, I went there. And textbook, I went through the case history in a minute and then quickly did a test for ketone bodies. Once I ruled out, uh, I assumed it was insulin hypoglycemic coma. And as you know, if you give hypertonic glucose, the patient sits up like in a film.
Yes.
So the high you get when you save a life like that, or even less dramatically when you cure an infection or something else and the patient is relieved of pain or suffering, it is extremely satisfying. So in that sense, I do miss it. At the same time, I don't think I could have made radically different choices. Maybe there were minor differences here and there, but my mind was made up when I looked around what was happening in the country from a democratic point of view. Are we as people of India getting what is due to us? And from healthcare point of view, because I realized quickly on that healthcare is much more than medical care. And unless a lot of other things come into place, the right kind of system being designed, care available to the primary, secondary, tertiary level, and of course nutrition, sanitation, water supply, and so on and so forth. Without all these, merely the stethoscope and the white coat, however wonderful the doctor is, the capacity of the doctor to make a difference is there, but there is so much more outside the doctor's province. Because I realized that I made choices in life. I don't regret that. So the answer is yes to both the questions.
Hello, sir. My question is what is the present healthcare system in India and how is it different from other countries in the world? And what do you feel for our society? What do you feel is the better healthcare system?
Dr. Natesh, no, we all during medical education, my education was half a century ago. I joined medicine in 72. And you're all much more recent. But in some form or the other, we all have studied community medicine, social and preventive medicine. I don't know what it's called now. So there is a standard format given. But what the books describe and what actually is happening in the country, unless we see the distinction, we'll be misled. On paper, we have a robust system, a primary healthcare, PHC, sub-centers, then community health centers. In states like Andhra Pradesh, Telangana, area hospitals, slightly larger, sub-district hospitals, then district hospital, then teaching hospital for tertiary care. But in reality, most of them are underfunded, hopelessly inadequate. B, there is no integration of primary, secondary, tertiary care. So the first point of contact for most patients is tertiary care or a private doctor in private practice, or even more tragically, a quack, an unqualified person doing some kind of voodoo medicine and hoping that you get something out of that. And therefore, overcrowding of the teaching hospitals in cities because there's no other primary care system available. You go to the accessible point. So, All India Institute of Medical Sciences gets 12,000 patients a day, the world's highest number. The nation's Apex Institute gets 12,000 outpatients a day. It's absurd. Your teaching colleges typically in India get about 2,000, 3,000, 4,000, 6,000 patients a day. So the system is completely lacking in integration. It's all isolated, whatever is there, very, very random. The third is the public expenditure is one of the lowest in the world, and out-of-pocket expenditure of the patients is one of the highest in the world, in fact, the highest in the world. As a result, the number of people who become poor on account of inadequate healthcare is extraordinary. That number is larger than most nations in the world. 6 crore people in a year, 60 million people in a year become poor when they were not poor in the beginning of the year only because of bad healthcare. So, overall, we have some great strengths. Doctors like you, every year we're producing 80, 90,000. We have some outstanding clinicians, and our high-end interventions are at very low cost compared to global prices and the global standards in terms of safety and the record of relief, etc. Our pharma industry is a world champion, so we have a lot of grades, but we have absolutely third-rate healthcare system which is not serving our people. So therein lies the opportunity. There is a need, desperate. There is also a great opportunity because we can do things much better than most countries in the world.
So, what do you suggest the change should be there? What changes have to be done to the existing healthcare system?
Now, in medical training, we are all taught the importance of diagnosis. The most important thing is understanding what is the problem. Otherwise, you give random prescriptions. What's happening today in the country is random prescriptions. The union government, states, they say we'll start more medical colleges. You keep seeing headlines. Actually, that's not the problem at all. Many people who are outside medical profession or outside the healthcare sector may find it surprising. We have about 1.2 million, 12 lakh doctors, qualified MBBS doctors in India. We are producing about 90,000 to 1 lakh doctors every year. We don't require more doctors at all. We require these doctors accessible and better oriented towards taking care of the needs of our population at various levels. It is not more doctors. More doctors don't make any difference at all. Already existing doctors, probably about 250,000 of them, 250,000 of them, in my judgment, are either underemployed or unemployed. It takes genius, great genius, to design a system where you have many, many people who require doctors. You have many, many doctors who don't know what to do. What a mismatch, what a tragedy. So the problem is not lack of doctors. First, we must understand what not to do. The random approaches, or you suddenly spend 100 crores or 200 crores on one nice diagnostic center or something else. All these are necessary on paper. But that's not where the money should go, not in a random manner. There must be a proper integrated structure. A must be accessible. Everybody in India, the rich, the poor, the villages, the urban areas, without any burden in the pocket, they must be able to access healthcare. B, it must be effective. It must not be a voodoo health. It must be real healthcare that actually improves the quality of health and reduces expenditure for them. C, therefore, it must be affordable, both for the individual and the country. Because healthcare expenditure, it's a bottomless pit. You take America, America spends about 18% of the GDP on healthcare. America is the richest country in the world. And then in that country, about 1/5 is spent on healthcare. Half of it by the government, half you and I, the citizens, pay for insurance premiums. But America is nowhere near the top in healthcare outcomes. Expenditure-wise, it is top. Probably it is twice or thrice the second highest spending country. But outcomes-wise, it is 35th or so. It is the way you design it. You put more money, but how you design it is more important. Otherwise, healthcare expenditure is a bottomless pit. No society can afford it. America is worried. Britain is worried. France is worried. Germany is worried. Australia is worried. Canada is worried. All rich countries are also worried about healthcare expenditure. So we must design it intelligently. We can go into a little more detail, but basically, we have looked at some things. In a brief discussion we have seen, Natesh, we have plenty of doctors. They're reasonably well trained, though the clinical skills could be better. We have tremendous clinical material, but clinical skills can improve. That's a matter of training and some orientation. We have very good quality infrastructure in public and private sector, diagnostics, as well as the pharmaceutical industry and the private sector hospitals. Today in India, annually we are getting about $14 billion of income serving the overseas patients. This year we expect 1 million patients to come to India and get healthcare treatments, high-end surgeries and other interventions. And India is going to earn about 1 lakh crores, a trillion rupees. Good. We can actually reach 100 billion, 7-8 times more. But that does not help our people. I'm all for it. I'm all for earning more money by providing services to the rest of the world. But simultaneously, you must design a mechanism by which our people get quality healthcare at an affordable cost. So what it means is leverage our strengths. Don't look at phenomenal expenditure. We don't have that kind of money. Our governments are very poor. They're always starved of resources. So with a low cost, how do you get high impact? So what I believe we should do is look at each sector in isolation, separately, but in an integrated manner. The primary care, the first point of contact. I'm not talking about public health, water supply, sanitation, sewerage, immunization. Some efforts are going on, they can be improved. But I'm talking about the medical care part of it, the primary care. The present system simply is not serving the needs. When we have hundreds of thousands of doctors available, if only you provide a mechanism by which A, the doctor is accessible locally, B, why should the doctor come? After all, these are very highly trained people, some of the finest youngsters in this country. Medical entrance is a highly competitive thing. Every year, I think 10, 15 lakh, 20 lakh people in the country appear for those examinations. And to get a medical seat is a great source of joy for those families. So unless there is a reward, they will not come. So there must be adequate return for the doctor, commensurate with the training and skills, and there must be competition to ensure accountability. Competition among providers and choice to the patient, because if you say, no, I'll put them as government doctors, I'll give them a monthly salary and they'll work, we have seen it all. People have no faith in that.
Yes.
And all this must be in a cost-effective manner. It must include also diagnostics. Now, for each doctor, if you want to have diagnostic laboratory, the cost will be impossible to meet. It's not economical. You must figure out a mechanism by which you can pool them. And then there must be prescription drugs available without any expenditure out of pocket. Again, for each doctor, if you want a dispensary, it's impossible. So you have to pool them. All this basically means the first point of departure should be identify small towns. In all of India, probably you require about 10,000 such small towns, 8 to 10,000 such small towns. In states like Andhra Pradesh and Telangana together, you probably require about 400 to 500 such places. In each small town, which is already with urban amenities, encourage young practitioners, medical doctors fully trained. You can give them some orientation, a month's orientation, just so that family practice. Now, in all medicine, we are taught all sophisticated stuff. I remember in my clinical medicine, the first thing we were taught in those days was mitral stenosis, rough and rumbling, mid-diastolic murmur and so on. It's all nice. But in common family practice, you don't require to really bother too much about those stuff. Not that you should not learn mitral stenosis or regurgitation, but you have to basically understand the disease profile of the population. At the first point of contact, what you should look for, how you should manage, and when and where and how you should refer. So that orientation is important. Once these, let's say in a small town like that, for a population of lakh and lakh and a half, about 10 or 12 doctors are available like that. You must provide a mechanism by which per month they get a net income after expenditure of 1 lakh rupees. And for a young doctor, early on, 1 lakh rupees per month is a decent income in my opinion, net income. And after some years of doing that, if they feel that they can do post-graduation, already we are providing facilities in post-graduation, these in-service candidates get preference, or they want to do private practice, or they acquired enough skills and they want to do something corporate, it's perfectly okay, because every year we're adding 90,000 doctors in the country. So there'll be a circulation. They get trained, they hone their clinical skills, people get care, they get adequate income, and they get income only on the basis of the patients coming to them. Because there are many practitioners available, patients choose whether they want Natesh or Dinesh or Tejaswini. You're not forcing them to go to anybody. We make a choice. Therefore, their reputation, the quality care they provide, is what is going to give them better practice. So there's competition, there is choice. And then ensure there's a referral service. And for all these 10 doctors in that small town, ensure there is a diagnostic center High-end diagnostics, like in Andhra Pradesh now, you can devise a mechanism by which public-private partnership is there, cost-effective but quality diagnostics, and dispensary for all these 10, 12 practitioners, the free dispensary, the government controlled, not necessarily government owned, so the drugs are supplied. So all this can be organized, and it will dramatically change healthcare scenario. Secondary care, what we are doing, just expand it a little bit. Your Aragyasri, your Ayushman Bharat, whatever, you have to expand it, make it universal with certain changes. Tertiary care is where you have to do a lot of thinking, because you have hospitals which are hopelessly underfunded. So the challenges are how to fund them adequately, and two, how to bring back the credibility. The public trust and credibility which were there when we were students, the government teaching colleges were the best. The doctors are highly regarded. Today, I don't think even middle classes are going to government colleges, teaching hospitals, whatever be the reason. So we had to bring back the credibility and trust. Fine, brilliant practitioners, reputed practitioners like all of you, must be encouraged to come back here, not on regular basis, not for a salary, but you do your own private practice, but come here as a consultant, give X amount of time, because teaching is a very prestigious
Gratifying.
thing. So the finest practitioners, they are gratified to come and teach. So give them that opportunity, a reasonable system, a contract by which their services are provided, so that the teaching hospitals and government get the service of the best. And they must be the centers of tertiary care in government. So a very well-designed system at a moderate cost, with integration, accountability, and cost effectiveness. It's possible to design. That's the purpose of this kind of a thing. It's not something beyond our imagination. It's not something we cannot afford. If I say, I want 10 lakh crores a year, of course, other countries are spending much more money. We don't have that money. Just because you and I shout from rooftops, you'll not get that money. So what is affordable? What is possible? All this is possible at 0.4 to 0.5% of GDP. Other countries are spending 10%, 12%. I'm saying we are spending now 1%. Just add another 0.4 or 0.5, but properly. Design it well. You will see a radical improvement.
Why not direct taxpayers be given health insurance from the governments?
It's a good question, Dinesh. Rich countries have the practice of health insurance, but even they do not all have health insurance. America is a country which is based almost entirely on insurance. See the experience there. In America, for the elderly people, they have what is called Medicare system. You pay from your wages in public sector or private sector, and employer pays a part until you retire at the age of 65 or something. Above 65, there's free care. So even in America, insurance is not working for the large proportion of population above 65. Remember that. And most healthcare needs are where? Aged population. And similarly, for the indigent poor and certain other categories, there is something called Medicaid. Again, that part is not covered by insurance. The rest of it is covered by insurance. Every citizen buys insurance. I already told you how much money is being spent. The total money spent by the government or by the citizens is about 18%, 19% of GDP. But America is 35th in the healthcare outcomes. So insurance gives you an illusion in healthcare of the cost being met because I paid the premium. When there's a catastrophic expenditure, a sudden unexpected expenditure, instead of my family becoming bankrupt, the insurance, actually I am bearing it, nobody else is bearing it. Except that collectively there is risk pooling. So there is a satisfaction that in times of crisis my needs are met. But what is the downside of that? Number one, it will not work unless I am a regular worker with a monthly wage. That means organized sector employment. The countries with insurance have 90 to 95% people in the organized sector employment. So if you are working in an organization, you pay X amount like Provident Fund towards health insurance, and the employer may pay as per the job contract. In India, 92% of the workers are in an unorganized sector. There's no regular job. There's no monthly wage. There's not even a regular wage. One day you may get some work, you get some payment, next day you may get nothing. So you don't even have a mechanism to collect insurance even if you want. Two, insurance by definition means high-end care is private sector driven. Now healthcare costs skyrocket enormously. To build a decent tertiary care hospital costs about 1 crore to 2 crores per bed. You are an orthopedic surgeon. You know how costly it is, trauma care or something else, or internal medicine, critical care, or pulmonary care or something else. No, it's not the doctor's fault. Modern medicine also means modern technology. Modern technology is improving every day. New interventions are coming every day. They're very sophisticated. An MRI costs about $1 million. That is 7-8 crores in Indian rupees. A CT scan, depending on the kind of CT scan apparatus you want, costs about 2-3 crores. A PET scan costs maybe 10-15 crores. If you want stereotactic radiotherapy, it costs about 20-30 crores. Each is like a big factory. All this in one hospital in a poor country. So you can't blame the hospital or anybody. The costs skyrocket. Therefore, the cost of care cannot be brought down because your insurance does not take care of the primary care needs. It takes care of the hospital's catastrophic expenditure. So what is happening? You are driving a primary care problem into a catastrophic problem. Instead of dealing with the person early on, identifying it and managing the patient with hypertension, let us say high blood pressure, or diabetes, blood sugar, or some other problem, instead of dealing with them early on and properly managing the patient, you allow a crisis to develop, then have dramatic interventions which are very high cost with low impact. That is the logic of insurance, the way it works. And the third problem with insurance is, it's very well known, the markets do not work in healthcare beyond a point because there is asymmetry of information. The patient does not know enough, is always very worried. If the healthcare provider or the insurance company knows much more than the patient. Therefore, an honest bargain does not work. Sometimes a clever patient may overuse the facilities because anyway I'm insured, therefore even if I don't need it, I will try to use my judgment and push the system to go for high cost after I'm not spending money. In America, it's very common. Pharma companies, we all know, drugs keep on getting improved. A drug is available, it's open source, anybody can now manufacture in the world. It's no longer called intellectual property. Therefore, the price can be controlled because of competition. What do the pharma companies do? They modify it a little bit. There is no improvement in the efficacy. They put the cost 10 times or 20 times more because now there's intellectual property, the patent rights, and they market enormously, telling the people this is a fantastic drug. Now, a patient with insurance cover, when I don't pay out of pocket, supposing the doctor gives me a choice of a drug that is costing 1,000 rupees, the same thing costing 10 rupees. The doctor knows both are the same, but the 1,000 rupees is allegedly a new drug. They're advertising heavily, and I don't pay anything extra. What would I choose?
Obviously, high.
Because there is a mistaken belief that the higher the cost, the better it is. For people to understand, recently, for instance, for COVID, Molnupiravir has come. Now, the drug companies in the US, they priced it at $700 a tablet. $700, it takes 10 tablets, a course of 2 tablets a day, 5 days. $7,000 for a course for one patient. Our companies could bring down the price to 125 to 130 rupees a tablet. 5 lakh rupees there, we can do it at 1,000 rupees here, or 1,500 rupees. Now, that 5 lakh rupee fellow comes up with a minor change without any improvement in the efficacy and prices it high. So this is very common. These are not mythical problems, these are real problems. World over we are seeing. So adverse selection is one other thing. What happens? When I feel I need health care, I'll have problems, then I buy insurance. If I feel I'm healthy, I don't buy insurance. So what is happening? The cost of care for those who are insured is becoming very high. Insurance works on the basis of risk pooling. If 100 people pay insurance, only 1 or 2 get serious disease, therefore the 100 premiums can be spent on 1 or 2 people. If only the 10 people likely to get the disease by insurance, the 90 who don't have the problem, they won't buy insurance, then it will not work. It will collapse. So what will happen? Premiums go up. Because more premiums there, healthy people even further get out. Earlier, some of the healthy people may have also gone into it. Now the premiums are so high, the risk is so low, I don't want to be a part of it. I'll come out of it. So adverse selection. So insurance in our conditions will not work. It can work judiciously. For instance, your secondary care, your Arogyasri in Andhra Pradesh, Telangana, or your Prime Minister's Ayushman Bharat, these are insurance-based systems. It's all started from Andhra Pradesh. For secondary care, judiciously used with certain modifications. For instance, you must take away tertiary care interventions, very high-cost interventions from there. 50% of all the expenditure on Arogyasri in Andhra Pradesh, for instance, is on 4 interventions. One of them is orthopedics and trauma care. One is heart surgery.
Cardiology.
Another is cancer. The 4th is kidney problems. These 4 take care of 50% of the total cost. If you relegate most of them to tertiary care, but cover every secondary care intervention for all the population in a judicious way, because already we have a robust platform. A secondary care insurance model, Arogyasri model is there. If that is modified for that limited chunk, insurance will work well. But if you include tertiary care, in a country with abject poverty and high cost care at the tertiary level, it simply collapses. So insurance is not a viable model for the bulk of the people, for the propertied people with a good regular monthly income, knowledgeable people. Already they are buying insurance, and that will continue to grow. And the private sector tertiary hospitals primarily will cater to those needs. Because whatever you do, about 30% of Indian population will depend on private sector. They will pay. They will be happy to pay. For them, insurance will work. For the rest of the people, insurance is not a viable option.
Actually, the money spent on Arogyasri, it can be utilized in some other way. Like if they want some specialized doctor, the government can provide facilities or treatment facilities in a government place, and a couple of doctors or 4 or 5 doctors in that particular city can come there and offer their services for some PPP model.
Absolutely.
And
You are
the
right.
costs from Arogyasri can come down, and at the same time, the patients will be able to receive best of the treatments from best of the hands.
You are absolutely right, Natesh. You know, Arogyasri actually is a good model up to a point. At least now I'm very happy that we focused attention on healthcare. The reason why Andhra Pradesh people and we can be proud is that we started this process. Dr. Rajasekhar Reddy, he must be giving credit for that, recognizing the importance of healthcare politically for the first time in India. Therefore, a robust model has come about. But if we think it has universal application, we are wrong. But judiciously used the way you're mentioning, improve the public hospitals at tertiary level and limit secondary care interventions to a certain relatively moderate cost but universal application, and increasingly go towards small nursing homes. See, Arogyasri initially worked well because the new private hospitals, they all embraced it. Now, if you notice, my understanding is, because you're practicing, you would know better, most of the private tertiary hospitals are not interested in Arogyasri model because it's not cost effective for them.
Yes.
Because a very high quality tertiary hospital is very, very costly. They can't afford these prices. Whereas 30, 40 bedded private nursing homes, small nursing homes, where typically wife and husband or 2 doctors, they live in the same place, available 24 hours, they bring down the cost, ensure quality, they have patient interaction. There the costs are perfectly okay. And access also improves because they're all locally available. You don't always have to go to Chennai or Hyderabad or Bengaluru or Mumbai. So judiciously we must understand our conditions, where the best advantage is there in a model. So Arogyasri, I think, is a very good model, but with the application limited to secondary care in an intelligent manner. Universal care, secondary care, and small nursing homes being the mainstay. Otherwise, Arogyasri also eventually will die. Many, many hospitals that embraced Arogyasri are no longer in Arogyasri. Many people are forgetting that.
Sir, how do you decide in the proposed model which cases to be treated as primary, secondary, and tertiary?
Primary is the first point of contact.
Secondary
That's
and
not a
tertiary.
problem. Secondary and tertiary. See, I mentioned to you the 4 sectors where 50% money is spent. Broadly, we all know which require highly specialized management. Suppose something requires a ventilator. By definition, it's a tertiary care problem. ECMO or ventilator. Any heart surgery, any neurosurgical problem, orthopedic surgery beyond ordinary fractures. Ordinary fractures are secondary care problem. But if you have multiple fractures, trauma care, etc., obviously you can't handle it as secondary care. It's a very sophisticated intervention that is required. Spinal surgery, for instance. So I think it's more by exclusion. You identify the 10 or so areas which require tertiary care attention. Everything else is, as a rule, general secondary care part. I would look at it that way. The high cost, low impact, very sophisticated interventions we identified. Tamil Nadu has identified, actually you can go into the list, I have all the lists there. You can go into Andhra Pradesh, you can see other states. You already have a good idea. They are taking away the bulk of the money, but with fewer patients. Whereas secondary care, insurance model must actually deal with the bulk of the problems for all the patients and excluding tertiary care and provide for them separately. Otherwise, this is going to take away all the money without improving the healthcare outcomes.
So, as you've said, we have to bring back the glory and trust for government hospitals. So, in a way, we have now A category, B, and C category seats, but in government, we have only A category. So, the people who are paying around 1 crore or more to private hospitals, if we could add that to government, like B and C category, we can develop our government hospitals, develop the infrastructure, and also more number of seats can be increased in government sector.
Tejaswini, you're absolutely right. There is a lot that needs to be done to transform medical education. In our model, we have not really addressed that. We have looked at the care. We didn't look at the supply of doctors because NMC and others hopefully will do the hard work required to transform medical education. I think there are three things that are required in the medical education and the teaching hospital management, very broadly. The first is, as you said, a more robust mechanism to get admission into medical schools. At least now, on the whole, we have a competitive, objective model. As long as it is honestly held, we are happy with that. But as you said, this ABC, etc., some colleges charging practically zero fee.
Yes.
I did not pay a single rupee for medical education. Actually, I received more scholarship than the nominal fee they charged. So I got money for studying medicine rather than paying. That luxury cannot be there anywhere in the world. My daughter, who also went to a government college recently, Gandhi Medical College, I think the annual fee was never more than about 10,000 rupees. Even that I had to urge, no, when are they taking money? I don't remember any time the school management, the medical college management saying, please pay the fee or something like that, which is ridiculous. I mean, today you can't get an ordinary primary school with less than 40 or 50,000 rupees annual fee, and medical education, the highest quality of education in the world, being underpriced is not a very smart thing. So we can have more equitable distribution. But even more important is the quality of training. Our theoretical training, in my judgment, is very, very good because these are brightest youngsters. There is no other country where there is greater competition for medical admission. India gets the brightest brains into medicine. And therefore, the master theory, nowadays we have the technologies, we have access to knowledge. But the clinical acumen is not as sound as it should be. Though we have immense clinical material, the emphasis from clinical training is somehow shifted. So I think we have to radically transform the nature of examinations. We have all the material, clinical material. So you don't require to create any further infrastructure for clinical material part. But you require the incentive to master the clinical knowledge. Something like the objectively structured clinical examination, OSCE as they call it in Britain, or some other models. I'm sure these are easy. They don't even require changing the medical council regulations. Simply devise an examination system to suit the needs, because medical tests, as you know, 50% anyway are supposed to be clinical knowledge. Only 50% is theoretical. So on paper it's already there, but it's not tested soundly. It's time that we took ourselves seriously. Otherwise, what's happening after doing medicine, many bright young doctors don't have the confidence to practice immediately.
Also, a lot of them are choosing to move outside India. There's brain drain, they're choosing UK.
Because the training is not adequate here. Honestly, The kind of knowledge that you have to acquire in order to be a first-rate doctor abroad is much greater than what we have here. Our kids are capable. They're as good as them, but they're not asked to do that. Our examinations, your Usmania question bank or Gandhi question bank or some other Falcon or whatever, and our kids know how to master them. Everybody gets a first class. So it's just a little bit of tweaking. If you do that, and finally, if you bring back the glory to medical teaching, I am sad to say that only a small proportion of teachers in government medical colleges at least are inspiring. Others don't inspire much confidence. It becomes routine. There, by a flux of time, because of seniority and age, some of them became teachers without the aptitude for teaching or without the credibility or the public trust. We cannot now change it by salaries. We have to encourage the finest practitioners in private sector to come to teaching hospitals and teach on a part-time basis or an agreed basis. They'll be happy to come. So if these three changes are made, I think medical education, the rest of the things automatically will take care of themselves because we are getting the finest talent. That's our good fortune. There's a great demand. We can easily improve this. I don't see any difficulty at all. Maybe I'm a great optimist. I don't see the hurdles. I only see the possibilities. But I see immense possibilities. And it's much better than the problems of other countries. You don't have medical colleges. They don't have medical students. They don't have trained doctors. They don't have trained nurses. They don't know what to do. They don't have skilled people. We are so lucky. And many of you and your seniors, after graduating here, they went abroad, acquired the finest skills in the world. They came back and transferred those skills to this country. For instance, knee replacement. Mr. Vajpayee, the Prime Minister, when he got knee replacement in India, that was a novelty. Not too long ago, just 20 years ago. Just 20 years ago, it was a novelty. Whereas today, in Hyderabad alone, I suppose, how many knee surgeries do they do? Knee replacements?
Definitely around 100, sir.
Exactly.
In Telangana. In Telangana,
Just
100 per
20
day.
years ago, a Prime Minister had to go to Mumbai to get knee surgery by foreign doctors. Today in Hyderabad alone, every day we do about 100. So we have such phenomenal advantages. Our doctors have done a great job. They made us very proud. We are not taking advantage of what is available.
What is your take on generic medicine and any bad side to that?
I am a great supporter of that. Long ago, they appointed a Hathi committee in India. In India, we are good at appointing committees and making statements and preparing reports. And therefore, if you are asked a question, they immediately say, we have a report, we have policy and all that. But in reality, we are bad at implementing. Bangladesh implemented it long ago. Compared to India, Bangladesh is a very tiny country. They've done it long ago. And India is the pharmaceutical giant of the world.
Capital of the world.
So, unless certain drugs, they are irreplaceable. There is no generic drug substitute available. It's possible because with new technology emerging, new medicines come, and as long as intellectual property rights are there, the patent rights are there, there is no substitute for them. For all others, quality generic drugs are possible, provided, this is a big proviso, in a country where regulation is weak, fraudulent, spurious drugs, I'm told in Delhi's Karol Bagh, there's a whole industry of spurious drugs. So we must protect the patients from this bad packaging or spurious drugs in generic medicines. It's not difficult. So if there is centralized procurement of drugs, and Tamil Nadu has started that, Andhra Pradesh and Telangana are now doing it, many states are following suit, where you can have quality control, you have better bargaining power in dealing with the pharma companies because bulk order you're placing, and you can monitor, you can have your own testing labs to see the quality of the drugs being tested. So if the precautions are taken, unless certain drugs are irreplaceable, there is no generic drug available. For all others, 80 to 90% of the drugs, generic drugs, eminently possible in India, but government must design the system.
In an era where health insurance is a must, so how far is India's dream of maintaining a digital health record for every citizen?
No, first of all, health insurance is a must is a very difficult thing to establish. We already discussed it. I'll come to that first and then we'll come to the other part of it. In all of India, we are now spending roughly about 9 lakh crores on healthcare. Government and private sector. Private sector spends about 75% of it. That means about 6 or 7 lakh crores is spent by the people either through insurance or out of pocket. You know what is the total insurance premium collected in an year in India? Out of the 6 or 7 lakh crores? About 28,000 crores.
Oh.
It is less than 5% of the private healthcare costs of India. So somehow our notion that no, my God, there is a vast health insurance, it's not true. It will grow. It should grow. But as I said, it will only be applicable to the organized sector and the better off sections who know how to buy insurance, how to get the best value for that. For the bulk of the people, it is simply not viable. First, you must understand. But irrespective of that, whether insurance or no insurance, we do require a health record system because as the demography is changing, as population is becoming more and more aged, and as the disease profile is changing, in the earlier days, almost every problem you see is an infection,
Yes.
or dehydration, or diarrhea, or malnutrition. While we still have those problems, the numbers are changing. Today, earlier probably about 50-60% of the deaths were because of infections and malnutrition and dehydration and so on and so forth. Today about 25%. It is bad. We have to bring it down to maybe 5% or something. But we are on the downward course. What does it mean? That 75 to 76% of deaths are because of chronic diseases of the aging. Heart disease, diabetes, hypertension, respiratory problems, cancers, and the like. As the disease profile is changing, most of the diseases require management. When you come to chronic, non-communicable diseases, there is no tablet or intervention you give and it is cured.
Yeah.
It is rarely that way. If I have high blood pressure, for life I have to maintain the blood pressure. My diet, my weight, my exercise, my lifestyle, and my regular proper medication. Similarly, if I have a respiratory problem, a chronic respiratory problem,
Asthma.
then for life I have to maintain that. If I have diabetes, for life I have to maintain that. There is no one drug, 1 week's treatment, and you go back and you're cured. Of course, if you have cancer, much more complicated. Luckily, things are improving now. Survival rates are higher. So all these require an understanding of the patient and past record. That's when management will be most effective. You can quickly diagnose, you can quickly intervene, and you will do the best for the patient. Therefore, health records, it was always necessary, but we ignored. Today, it's much more necessary than ever before. Because the aging population, though we are still a relatively young nation, we are also aging. You take the southern states, in every single state, the number of children is decreasing every year. Number of births is decreasing. All the pediatricians and obstetricians will tell you the number of births is decreasing, which is good. We want to control the population, right? So we were still thinking of the 1970s, when every year the births are increasing and children are increasing. That's not true in large parts of India. So elderly people who have most problems, chronic problems. Tejaswini wants to do rheumatology. No, rheumatic problems we all know. Whether it is osteoarthritis or rheumatoid arthritis or spinal problems or something else, these are all problems of aging. So unless there is a proper health record system, a lot of clinicians' time is wasted. A lot of care is delayed. Sometimes there can be wrong care, misdiagnosis because you don't have proper history of the patient. So it's absolutely necessary, but you can't do it overnight. You can't do it overnight. We have the technology now. Therefore, if you slowly build the technology and make sure there is compatibility of these records in the private and government hospitals across the tiers, primary, secondary, and tertiary, that is the most important thing. So that any machine can handle all these in a uniform manner. Then slowly, you build the record system. Over a period of 5, 10, 15 years, the system will be built. I think that's a robust kind of an approach, a practical approach.
And even for migratory populations,
Absolutely.
it will be useful.
That means each person must have a unique number. Already we have Aadhaar,
Aadhaar.
etc. So with the patient's consent, with nobody else accessing it, the patient, the doctor, with the patient's consent, can access any time, anywhere, private or government. That is what we must aim at eventually. But it's a very long process. India is good at it because, for instance, our financial transfers, for instance, UIP or UPI, is
UPI
it?
transactions.
UPI or other things, though there are some safeguards required, but we are doing pretty well. India's Aadhaar itself is a great success. So this is not difficult, but there must be conscious effort made, and that must be integrated with the primary care in the model that we are designing. So unless we do it from the primary care onwards, only hospital care when the patient comes, it still becomes random. Ultimately, we must have a proper health record of the patient on a sustained basis. It's not a one-day operation. Telangana government wants to survey every patient and then build a record. Good, but it's not enough. What we require is a running record on a permanent basis. It's not a one-shot affair. It's not a one-day affair. India is good at these military-style one-day operations. No, we require a permanent system in place.
Public health a national subject or a state subject?
Healthcare is a state subject, and I think that's good. I don't feel bad about it. There's no problem with that. But everywhere in the world, while health may be a state subject in federal countries, the federal government plays a very vital role. In fact, world over, about 50% of the expenditure is by the federal government. Typically, 50 to 60%. Only 30 to 40% is at the local and state level. India is an exception. Overall healthcare expenditure, only 25% government is spending in India. Elsewhere in the world, from 60 to 90%. Even in America, it's 50%. So there already governments are weak in India. Within that, in those countries, federal government spends half of the money, the state and local half. In India, 75% is at the state level, local is hardly anything, 25% is federal level. So if ours is very skewed. The union government's expenditure must go up considerably, but it must be a state subject, and because the state flexibility is required, states innovation is required. If you bring a uniform thing, impose on the states without regard to the local conditions, the states will not want it, you will not do justice. Because it's a state subject, we could innovate the Arogyasri here. Now the whole country is adopting it. Something else we can do. For instance, the Andhra Pradesh free diagnostics scheme, it's the first in India, very successful, a good model. Again, we innovated. Tamil Nadu's centralized procurement of drugs, a good model. Other states are emulating. So when multiple efforts are made, a lot of innovation is possible. The best practices can be adopted nationally increasingly. So I think it should remain as a state subject. To the extent it should be national, that is, the protocols cannot be state level. The science and technology, validation of that cannot be state. It has to be national. ICMR or somebody else, they have to take care. Vaccine procurement,
Central.
it has to be. Then pandemic control, epidemic control. So, because these cannot be handled locally. There are many disadvantages of that. And medical education, it is always national. The control of technology, technical parts of education, Medical Council of India or the National Medical Commission. It can't be each state, each university doing its own stuff. So that is rightly at the national level. Rest of the things must be a state subject, but the union and the states must work together. They're already working together, but there must be much greater involvement and much greater funding, but in a sensible manner. It's not more money alone, it's better expenditure.
Is health should be included as fundamental right?
You know, we are very fond of including everything as a fundamental right in India. The danger of this kind of a discussion is we make a massive effort, big publicity, headlines, and say finally the constitution is amended to make it a fundamental right and we solve the problem of healthcare. It is a lie. What we need is healthcare to be accessible to people, available to people. You right there or not is irrelevant. I'll give an example of education. I think the 83rd Amendment, if I'm not mistaken, 83rd or 82nd Amendment, made education the fundamental right. As if without including in the fundamental right, the government is prevented from giving education to us.
Right.
And after including as a fundamental right, has education improved? Absolutely not. If anything, the outcomes today are worse than they were then. I'm not saying this casually. In Telangana, when they did a survey, they found 50% of youngsters between 14 and 18, they could not read the time in a watch. This is about 10 years after education became a fundamental right. 2018 this happened, this survey. 50% cannot put the appropriate weights while measuring the weights in a balance. Between 14 and 18. So we must get health care. Not a law saying it's a fundamental right. Nobody is preventing the governments from giving health care. And by simply putting it in the law, it doesn't mean healthcare is guaranteed. It's not a mantra. So to me, it's irrelevant. In fact, I don't want effort to be wasted. Many people are fond of fundamental right. The danger of that is there's a pretense that you have done something great by including it in the constitutional amendment. All the attention is on that, forgetting actual delivery of healthcare.
How can we make people and our citizens understand that there is a direct link between people being thrown into poverty and proper health policy?
Nagesh, I think people understand first part of it. They may not understand policy. They understand that ill health is the single biggest cause of poverty. The poor understand it. The problem is they have given up on government because of 60, 70 years of shameful criminal neglect of governments and political parties. People no longer believe that it is the government's job at all. They have given up on the government. So they are trying to do whatever they can. Go to a local Ved or somebody, go to some quack, or go to some doctor available. If you are in Hyderabad or Bengaluru, go to a teaching hospital and then flock it for simple problems. We discussed our Institute of Medical Sciences gets 12,000 patients. Most of them are patients that should go to a primary doctor. If you have a simple case of malaria or a viral fever or a cold, you don't require to go to a teaching hospital. It's absurd. But because there is no other access of healthcare, you are going there. So people know already, but they have given up on government. The problem is that it is the government's central responsibility to provide quality care without out-of-pocket expenditure that is not internalized. So what are people asking now? Election time, give money for voting. Andhra Pradesh, Telangana have become the masters of that. And quite a few other southern states like Karnataka, Tamil Nadu, etc. Other states are following suit sadly in the country. Or freebies. Not education, not quality healthcare, not infrastructure, not job opportunities. No. Freebies. Per month I'll give you this much, I'll give you free power, I'll give you free this, free that. But poverty is not ending. So people understand the pain of healthcare. They are not looking at the government as the solution, as a part of the solution. In the process, what's happening? You are wearing beautiful white coats and the stethoscopes. You are seen as the visible symptoms of healthcare system. So a patient who is angry, not getting the healthcare that she needs or wants, had to spend a lot of money out of pocket because there is no proper public health system available. The anger, they're lashing out at the doctor.
Yes, sir.
30, 40 years ago, people in your place, they were treated as gods by the patients.
Yes, sir.
Patients were, I remember, when I was doing medicine or house surgery, patients in the most part were very grateful. We tried our best. Conditions were much weaker, much poorer than. Technology was weaker, resources were fewer, infrastructure was much, much worse. But despite that, we did the best under the circumstances. And people understood that. They appreciated that. Today, I don't think many doctors feel the appreciation. They feel the resentment. They feel the anger. They feel the suspicion. The public trust is broken. It is terrible for the society because not only is it bad for the medical profession, doctors work very hard, they live tremendously tense lives. Doctors' lifespan is shorter than the rest of the population. The people who save lives actually live shorter because of this anxiety and stress. So it's bad for the profession, but it's bad for the patients and the society because the faith in the doctor is about half of medicine.
Yes,
If I don't have faith in the doctor, trust in the doctor, to that extent, no matter what interventions are made, what medicines are given, they will not work as effectively as they should. So society is suffering in the process. Medical profession is suffering. So all this can be altered only when the government and the political system and the media and those who understand the role of the government, they realize good quality education, not any education. We have free education on paper, mostly third rate, but real good quality education without having to pay out of pocket, at least at the school level. Good quality health care without having to pay out of the pocket, at least for those who can't afford it. For the rich, they'll find their own means. In India, even if you say, I'll give universal health care, the rich people will not use it because already the practice is gone. They won't trust the government doctors and government hospitals. So be it. If they have the money, they have the means, let them do it. But the 70% Indians who utilize it, they must get free care of quality with competition and choice, with accountability. So unless we push the system towards that, there will be tremendous tragedy in the country. And good news is, slowly politicians are realizing. Andhra Pradesh, when they start Arogyasri, it's not only good for health to some extent, it gave them votes.
Yeah.
In 2009, Congress party was re-elected in large part because of Arogyasri. Many governments in the states and many parties realized that. So they all followed suit. National level, they are doing it now.
Yes.
For the first time in India, they are recognizing there is vote in healthcare. The COVID pandemic exposed the vulnerabilities of the system. So they may not understand why or how, but they understand what needs, that healthcare should be improved. That people understand, because during COVID peak, lakhs of families, they lost their families. Somebody, a member of the family, they didn't have enough oxygen. They spent abnormal sums because of poor infrastructure in times of crisis. So people understand. Now it is for the political leadership and the media and the medical profession itself to make people understand that there is a solution available.
Yes.
People understand the need for healthcare, but they have to figure out that the government must be the part of the solution. There is no other solution available.
So, why do you think there are a lot of pending huge bills to the private hospitals from Arogyasri, ESI, CGHS?
It is criminal, unacceptable, because already what we are spending is very, very little. Andhra Pradesh and Telangana together are spending less than 1% of GDP on healthcare. Andhra Pradesh is 0.95%. Telangana is about 0.7%. Already. That is union government's money plus state's money put together, total, spent in the state. Even that money is not spent properly. And the kind of money they're spending on Arogyasri, both the states put together, is about 1,800 crores per annum. It may be another 5% added. Year to year, there will be some increase. So 1,800 crores. The total budget of Andhra Pradesh and Telangana states, annual budget, is of the order of about 4,50,000 crores. 4,50,000 crores. 1,800 crores spent on Arogyasri is of the order of about 0.3% of the budget, not GDP. 3 rupees out of 1,000 rupees of the budget. With tremendous aplomb, they are committing themselves to totally unproductive programs worth tens of thousands of crores, which will not improve the lives of people, which will not reduce poverty. In Andhra Pradesh and Telangana alone, every year 45 lakh people are becoming poor only because of ill health. 45 lakhs, 26 lakhs in Andhra Pradesh, 19 lakhs in Telangana per year. These are the national sample surveys. It's not my data, these are government surveys. If you spend the healthcare budget wisely and make the improvements that we are suggesting, and these two states can do it very easily at a relatively low cost, 45 lakh people per year will not be poor. Even if you do nothing else, let's assume that both the states do nothing else, they simply sit back on that. In the next 10 years, there will be no poverty, zero poverty. So it is absolutely unacceptable. What they are doing is they want instant gratification. Give something which gives them vote that day. Actually, it's not true. They're not getting vote that way. Healthcare is a great vote giver if you actually build a system that gives satisfaction to people. And it eliminates poverty in the fastest possible manner. Every rupee you spend in government, in healthcare, is giving us 4 rupees return. I have done surveys in Andhra Pradesh and Telangana intimately. Every rupee you are spending is giving us 4 rupees return. It is unfortunate that they think others are priorities or profligate expenditure. They become like Maharajas, old-fashioned emperors, whatever is whimsical. That day something occurs to me, I say suddenly 50,000 crores, 20,000 crores, 10,000 crores, forgetting the basics. The government is about rule of law. Basic amenities like water supplies, sewerage, sanitation, stormwater drainage, infrastructure like transport and power, and most of all, quality education and quality healthcare. Everything else is secondary. Governments are spending a lot of money on anything but these. Whatever I mentioned are the lowest priorities. because they think they get the votes by simply giving freebies. That culture must change if we have to save our country.
Because of these late payments to even private institutions from government agencies like ESI, CGHS, Arogyashri cases and all, the private organizations are not becoming viable.
You're absolutely
And that money is being, that burden is being transferred onto the patients who are able to pay through insurance and just for their
you're
survival.
absolutely right. See, we are spending already extremely small amounts, the lowest in the world, and even that we are delaying payments. We are killing the private sector and killing the poor people, their families. There's no doubt about it. All of us must shout from rooftops every day, every month, and every year, and fight for the system to be improved. You're absolutely right. There's no doubt about it.
What would you think will be the future of private healthcare sector if your recommendations are implemented?
See, in the recommendations, there are 3 tiers talked about. Primary tier. Who are the people who are going to provide the primary care?
MBBS.
And private sector or public sector?
Public sector.
Private doctors, publicly funded.
Okay.
These are not government employees. This is private practice. The pharmacies, who will maintain, run them? Private sectors. The diagnostics, already in Andhra Pradesh, they're doing it. A company, private company is taking care of the diagnostics very well.
Medal.
At all. So, private sector. But publicly funded. So, we're getting confused between public provisioning versus public sector. Secondary care, all your Arogyashri model, who is providing the care? Most of it? Private sector. So, the only area where I believe private sector is not viable for the time being is tertiary care. The poor people seeking tertiary care interventions, there my belief is you spend more money on the public hospitals. You take, for instance, your Usmania or Gandhi, the 2 well-known government hospitals in Hyderabad, teaching hospitals. Typically, if there is a sanctioned strength of, say, 1,000 beds, typically there are 1,800 or 2,000 beds operating. Operational beds are nearly double in government. Because too many patients are thronging, they're demanding admission, they have some problem or the other. The superintendents and the doctors have no choice, so some floor bed, or they ask people around, get some charity, some bed. After all, bed is only a few thousand rupees, physically. Sharing. All kinds of things happening. On an average, per bed, operational bed, the money spent in a government hospital, teaching hospital, is 8 lakh rupees. That includes medical college and nursing college expenditure. Whereas in private sector, the billing per bed per year will be minimum 30 to 40 lakhs, in many cases 1 crore and more, high-end hospitals. Their government must put more money judiciously, improve systems of accountability, and attract the best private doctors to come in so that they get quality care. Those 3 things. And limit the tertiary care, free tertiary care with government expenditure to those hospitals. That's all. That's the only limitation of the private sector. Otherwise, primary and secondary are essentially private sector driven but publicly funded. And in India, given our social structure and the current conditions, the people who are better off anyway will only use private sector, no matter what you do. Conceptually, you make it universal care, but they have their insurance, they have their family doctor, private doctor, they trust them, they can afford to pay. And as our incomes increase, the paying capacity increases. Therefore, private sector continues unchecked. We must encourage private sector. I'm a great believer in that. I already mentioned to you about $14 billion is the billing this year for the overseas patients. This can easily become $100 billion in the next 10 years. In fact, even faster. That is much more than all the total healthcare billing in India today. That alone, overseas billing alone. So private sector will continue to grow, but the poor will not have to depend on payment in private sector, in tertiary care. That's the only limiting factor. So this will be good for private sector. This will be good for the poor people in the country and the middle class in the country. And as Indian incomes grow, we can move towards more and more insurance model, even for tertiary care. But right now, for tertiary care, that's not the right model. I gave you the reasons.
You are planning to meet 5 chief ministers and take forward this viable model of healthcare system in India. So, how far have you reached in your goal?
Natesh, health, as we discussed, is a state subject. And that's a happy thing. So you don't require government of India to take up for the whole country at one go. If the states take the initiative, once it's proved effective in outcomes and effective in terms of political support, like Arogyasri, initiated in one state, people appreciated that. They returned the government to power. So the other states embraced it. So the idea is to reach out to the states, particularly some states which are a little proactive. Take Andhra Pradesh and Telangana. We are the pioneers in Arogyasri. We are also pioneers in free diagnostics. We are also pioneers in central procurement of drugs, along with Tamil Nadu. So there are good things happening in some of these states. And we only have to do a little bit more, a bit of tweaking to make the system very robust and accountable. So that is the idea. We are now spreading the message. Our discussion also is part of educating the public, the medical profession itself, the media, the intelligentsia, and some of the better informed people. And once a buzz is created, we are confident that the states will come forward. And Andhra Pradesh and Telangana are doing a lot of positive things. And we are now designing programs specific to these states. Because while there is an all India pattern, unless we understand the local conditions in each state, the initiatives they have taken, the current status, etc., we will not be able to design a program of action for them. We are in that process for Andhra Pradesh, Telangana, and Tamil Nadu. Very soon we'll be completing that. Then we will call on the chief ministers and seek their support and their initiative and leadership in implementing this. I'm confident that it will happen in a few states, primarily from the southern states. And AP and Telangana, I'm sure, will be pioneers, the leaders in the country.
Thank you for your time and sharing your ideas regarding the healthcare system and the transformations that are required in our country, sir.
Thank you for the initiative you have taken. You have given away very precious time for medical practitioners on a Sunday. And what you're doing is important, because unless the profession wants this, medical profession is thinking that treating the patient is their task, yes, but it is a task. Medical profession also must provide leadership in healthcare, must be seen as champions of healthcare. Yes. And designing and operating healthcare system is more than medical care. And because medical profession is not seen as the champions of this, instead of being respected, they are being unnecessarily, unfortunately, criticized or resented. Because the patients don't understand where the problems lie. Therefore, they are attacking the doctors with the white coat. And I'm happy that you are becoming part of the solution. The people in medical profession, young people in particular, who seek a future in this noble profession, they must pay a little more attention to larger issues relating to healthcare, go beyond the textbooks of medical care, the way you're doing. And once they propagate the message, I'm sure that this will spread very fast. It will help the profession, it will help the people.
Thank you, sir.
Thank you, sir.